and we'll just go ahead and get started. So let's start by taking a look at what CMS says the purpose of HOPE is. And I think I'm going to highlight a couple of things that should be raising our antenna a bit, because we want to make sure that we are thinking way ahead of where HOPE is right this second. So obviously, assessment-based quality data, better understanding of patient care needs. And you can read, I won't read it for you, but I want to emphasize this one right here. The provide additional clinical data to inform, like red flag, please, future payment refinements. This is going to be a really important part of the reason we got started with HOPE in the first place. So I want us to think about HOPE not only as really improving our quality of care, really gathering more data, but also what could this mean for us as hospices into the future? There are 4 elements to HOPE: the admission or assessment visit, and then 2 what they now call HOPE update visits, or HUVs. One between days 6 and 15, and the second one between days 16 and 30. And then finally, a discharge visit as well, or discharge entry. Now, the other thing I think that is going to be really, it's probably part of the challenge of trying to figure out how to implement HOPE, are these symptom follow-up visits. So this is patient determined if they report moderate or severe pain or non-pain symptoms, and we'll talk, Carla will spend time talking about exactly what those symptoms might look like. Those visits must be done within 2 days of the initial assessment, 2 calendar days. They're separate from the HUV visits, and I don't know about you, but this last bullet, it can be done by either an RN or an LPN or LVN. That is really great news. CMS did that specifically because of the nursing shortage and the worry that many hospices were not going to be able to comply with this 2 calendar day issue unless we had a little bit more flexibility with staffing. Also in the assessment, there are expanded domains, lots of additional questions compared to what you see in the HIS today. All right, so 2 quality measures that CMS has been very pleased to be able to add to the HOPE process. One of them is the impact of pain. The other one is the non-pain symptoms. And you know this already. And here's the list, that very last bullet: shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, agitation, and other symptoms that you have collected on that assessment visit or on either of your HUV visits. And so the first place we're going to look is, this is actually a snip of the HOPE tool where you are asking about symptom impact. So I just want to call your attention to the little descriptor at the very top. Over the past 2 days, how has the patient been affected by each of the following symptoms? And so you're going to be talking to the patient about what the impact of these symptoms are for them. And then your coding is, you can see right there, 0, 1 through 3, or 9, and the code gets entered into each of these boxes. Now, what happens if it's a moderate or severe? So you rate it as a 2 or you rate it as a 3 based on what the patient is telling you about how it affects him or her. And then you're going to go to this second box, and you're going to put in yes, a symptom follow-up visit was conducted, was completed, and here's the date. Now, there are reasons for the SFV not to be completed. You can see the 4 listed, well, the 3 really listed there. And, you know, there are 2 parts to this. One of them is the symptom follow-up visit is attached to the HUV. So if you did the HUV on time, but you missed the symptom follow-up visit, that is part of your 90% threshold miss. So just pay a lot of attention to that. Let's look a little bit more closely at these reasons. No, this is kind of what we know about, we'll get to reasons in just a moment, what we know about the symptom follow-up visits themselves. So this is different from the HUV. They start with HOPE on October 1, 2025. And I want to clarify just for a minute, the October 1, 2025 is for patients who are admitted on or after that date. No telehealth visits are allowed, no phone calls are allowed, and no public reporting. Thank goodness, we need to get ourselves used to this until no earlier than November 2027 or FY28. Now let's look at the reasons why a patient might be excluded from some of the HOPE process. So they died or were discharged before the symptom follow-up visit was conducted. They refused. the hospice couldn't reach the patient or the caregiver. They traveled out of the service area, or they were in the hospital or ER. Now, one of the things I think we know because the spotlight is on all of us, but we know that if you said that your answer why you didn't do the symptom follow-up visit is the patient and caregiver refused. I'm just putting it out there that if that's the answer to most of the times when a symptom follow-up visit should have been done, that is really going to be a red flag for audits and for other folks to be looking at your HOPE data and saying, something isn't right here. So I just want to caution us that if that is the case, patient caregiver refuses, or really for any of these, you have the documentation to support why that was true. All right, Donnette, it's up to you now. I'm turning it over to you.
I often think about software design, and I've had the pleasure of working with a few vendors as playing Jenga. Because most of us, we are not using a software that is brand new, that was developed yesterday, and is just there for you to play with for the first time. No, it's existing. And you love that because you have all this code, you have all this big and amazing resources and features and reports and dashboards and all these things that you've been able to customize or you've been able to configure over time to meet your organization need. When you think about adding new code to that, it's kind of like playing Jenga. Not only are they looking at what they've done, they're also looking at what you may have done to that software as you have used it over time. The longer you've used the software, the most likely you have not only configured it, but you've also probably made some modification to it, which are all acceptable but still have to be taken into thought as you move forward with implementing a tool like HOPE. So what's different about HOPE? HOPE actually affects everything. It affects not only your documentation, but how you're going to communicate. It affects this amazing thing in all software, which is time. When are you doing something? Because if you think about it, every time a nurse goes to see a patient, the first thing they're capturing, or the one thing that they have to capture, is that time. When did I get there? Was I there for how long? All of that is time. And in software land, time is really important. It pivots a lot of different things, including billing. So as you're thinking about how you're going to implement HOPE, please do not forget that it affects all aspects of your business. Don't leave your billers out of the discussion. Please don't leave your intake folks out of the discussion. Don't leave anybody in your organization out of the discussion, because HOPE is going to affect everybody. Your partnership with your EMR vendor or EHR vendor should include three things: communication, and I've kind of touched on that before. Collaboration, I also touched on that, but also a commitment to work with them. And we're going to dive into these really quickly and not go too deep, because I know that Clara is going to take you a whole lot deeper than I'm going to take you. But I want to hit some things from the vendor perspective. First thing, there's some basic questions that you should ask about what your EHR vendor have in mind. But those questions should be asked after you have completed your own internal process review, because you need to be specific in asking those questions. What may matter to my hospice may not matter to your hospice at all. What will be important in my software may not impact your software at all because of the tools and features that are already built in. So it's important that you are asking specific questions. So for instance, section A, F, and I, where are they going to be pulling this data from? Where are they going to be pulling that patient name, date of birth, all of that from? They're probably pulling it from a vital place today, but some of this information will change. And you've already looked at, I'm sure you have, as you look at the HOPE document, you've seen where some of the his questions are going to change, and what they're asking for nationality and race. That's going to probably change a little bit depending on your software, but it's dictated specifically what it must be for HOPE. And you want to know, where is that coming from? Because that may change not just your documentation, but also where information is being documented in your system. Some of that content is actually being touched by different people within your organization. During that intake process, think about how many different people create that chart and build that chart and modify that chart before that patient is even admitted. So make sure you understand where this information is going to be captured, how often it's going to be updated within your organization, so you can communicate clearly about when that data is going to be pulled into that file that's going to be submitted to CMS. Also, for the clinical information, you also want to ask a lot of questions, lots of them, about these new visits. How are you going to know that an SFV visit is required? How is it going to be visible in the software? Is that just going to be to the clinician, or is that going to be to the back office? Will the back office be able to see it, manage it, do something related to that, just in case something happens to that clinician? All of that is information you need to know. You also need to know what's going to trigger that SFV visit in your system. Is it coming from the question? Is it coming from something else? Is it a manual thing that the clinician is going to be required to do? All of that is going to be important questions that you need to ask.
Thank you, Donnette, and thank you, Judi. So we're going to talk about what can you do right now. First, a reminder, what should that transition look like? Starting 10/1/2025, you are no longer to submit the HIS data. It's not going to take it anyway. But remember, it's being replaced by the HOPE assessment data, which will be completed by RNs at specific times during admission and at the 2 HUV visits. Many of the components are the same, but there are additional or more components in the HOPE tool. It's for all new patients. All new patients will receive hospice. All current patients who were admitted prior to 10/1 will move forward and only receive the HOPE discharge. You won't do any SUVs. You won't do any HUV visits. It's only the discharge that you'll put in. Some people wonder, well, to get all of my current patients into HOPE, what should I do? Should I discharge everybody and readmit them? Please do not do that. There's no reason for it. We understand that there's this cutoff that's going to happen, and anybody who was on your service prior to midnight, like 11:59 on 9/31, those people are exempt other than the discharge. No HUV, no SFV visits for those admitted prior. Anybody admitted at 12:01 or after on 10/1, they're all going to have the HOPE admission and the HOPE discharge. If they're on service by day 15, they will also have had an HUV or hospice update visit between day 6 and 15. Then there's another HUV visit if the patient is alive and still with you on day 30, you would have done the second HUV visit. And for some of your patients, you'll do both the SFV as well as the HUV. Then why HOPE? So we're going to look at different components of HOPE implementation. And the first is staff education. Staff education is going to be vital. They need to understand why HOPE is important to them. It's not just another thing for them to do that's meaningless. It actually could be something that will help provide information that identifies opportunities to adjust practices and improve patient care. It will give us data that's going to be publicly reported to show potential consumers why you are the hospice that they should choose, or that they should choose hospice altogether. It will in the future impact our reimbursement. And if you don't get the 90% submission of the HOPE data with all of the visits required, you will have a 4% deduction for non-compliance in your payment rate. And it can incorporate data into your care planning process. If something is identified as a problem for the patient, that should go into your care plan. It's in your problem list. You need interventions. And there are things that, as we talk further about QAPI, if you identified a problem, you do the SUV visit, and when you go back on the SUV visit, your interventions were effective, and they now say, no, I don't have a problem with that. That's really valuable information, as valuable as if they said, yeah, I still have a problem with the same thing. What were your clinical practices and protocols? Why didn't you fix that? So again, it can be something that can assist in care planning. It can help us create best practices. It can help us identify those areas that maybe our clinical teams are not as strong in that we want them to be strong in. It can help align our visits to the patient's needs, and it can enhance care, as I just said. Okay. Staff education. When you know how the EMR is going to work, you're going to have, as Donnette said, you've got to educate them on that. Remember, it's not a nursing assessment. It's the patient's perception of how they were affected in the last 2 days by each of the symptoms, whether or not affected, slight, moderate, or severe. In fact, CMS has validated that it's not a nursing assessment because they've allowed LPNs to provide that, to make the SFV visits. By state licensure regulations and by Medicare regulations, although we love our LPNs completely, we do know that they're not able by licensure to do a clinical assessment. So that's why we know it's the patient's perception. There are new things added that the HIS doesn't have. It's all the HIS items in addition to living arrangements, availability of in-person assistance in the home, skin assessment with type and treatment, expanded diagnosis list, the presence of imminent death, what the preferred language of the household is, whether there's an interpreter needed, and whether there's presence of neuropathic pain. So once you've done your staff education, you should take a look. Your QAPI division, whoever is in it, should actually be looking at the HOPE tool. If the system that you have live, if HOPE was live today and you didn't make any changes, let's just say starting today, you're going to look at, I didn't make any changes. If HOPE was live today, what would I score? Like, what are my practices and processes? So you could audit 20 records today to see if there was in the assessment at the time of admission, whether any one of those symptoms was marked as having a problem. Then look at, was treatment initiated that would have, and did you trigger an SFV? Was treatment effective at day 2? Because that would be when the SFV visit would be. What did you follow up with? Was it a phone call? Was it a visit? Was it at the next visit, which was a week later? You asked the question. So see, and then also look at the time and the date of documentation of those visits and when they actually hit your system. Okay. QAPI can also, you need to review your QAPI plan. What are you going to add to your QAPI plan that you're going to audit into the future? The percentage of visits not made and reason why: refused, not at home, hospital. What are the majority of your visits? We didn't make an SFV visit because they weren't at home, as Judi said. Percent of timely completion of the admission, the HUB1, 2, and SFVs. Clinical documentation timeliness. Auditing the timeliness of submission and acceptance into the IQ system. And we're going to talk about submission at the end. Do you want to use this as an opportunity to initiate a performance improvement project for the implementation of the HOPE tool? It's perfectly fine to do that. Do you want to pilot something? Do you want to take 2 RNs out of the field and say, I'm going to teach you how to do these HOPE things, give them the tools and have them for every admission that they do in the next 2 weeks, have them actually go through the HOPE tools that Judi provided with you and are in the resources at the end, and see how you would fare with that. So from a symptom management perspective, this is an ideal opportunity to look at how good you really are in all of the symptoms that are listed in the HOPE tool. And those are really things that the patients are really concerned about. And we as hospice clinicians want to make sure we're at the top of our game. So what's your current practice when a patient has a symptom that would have been moderate or severe based upon how it affected their life? Do you visit the next day? Do you call the next day? Do you visit within 2 days? Remember, HOPE is going to make you, to be compliant, visit within 2 days. What should yours be? What is yours and what should yours be? And when can you start that if you're not where you want to be? And then what's your definition to determine slight, moderate, or severe when the patient rates that? So there really isn't any clarification other than have the patient rate not slight, moderate, or severe. It's not a nursing assessment, although nursing assessment will, of course, be part of the conversation, but it really is the patient's perception of how this symptom has affected them. So all of that needs to be part of the conversation. Then what are your order sets right now, and are you going to have to change them? So you should at least have two PRN visits for symptom management in the first month of care, because you have a potential for 2 SFV visits, actually 3 SFV visits during that time, one from the admission assessment, one from HUB1 and HUB2. So do you want to hard code those in so that the nurse isn't creating new verbal orders? Then what education practice updates to achieve relief at the time of the assessment visit? So the SFV, remember, asked since the last symptom impact assessment was completed or at the time of admission in the last 2 days, how has the patient been affected by the following symptoms? Our goal would be that if we identified at the admission or HUB visits, that we would initiate treatment with a physician's orders, and we would make sure that that patient had relief so that when we went back for the SFV visit, and again, we say, how was it in the last 2 days? That they actually say to us, it was pretty good. I would say slight to none. Then that shows that your actual clinical practice is improving the care. The goal is that we have it's a lot better, and we're tracking it. In fact, it's part of QAPI. That would be one of the measures that we should be looking at. Now, if you receive orders and it takes you 4 days to get orders, then you've got a clinical practice issue, and you can identify that and deal with that. Okay. More about visit frequencies. Do you visit 7 days a week? You're going to have to if you don't. There will be times when the HUB wasn't done during the week and you're going to end up having to do it on a weekend, or it's going to trigger, you do it on Thursday and it's going to trigger a Saturday visit for the SFV. So one of the questions we keep getting is, will visit frequencies increase because of these additional visits? It maybe not. If you align your visits to that, it actually might not increase. It might be the number of visits you're doing now. What I'd ask you to do is look at what your visit practice is, and all of the administrators are going to say, well, we generally, we visit based upon the needs of the patient. But get down a little bit further down to the staff level. You likely have some of the nurses, or at least I know I used to have some of the nurses that had Monday, Wednesday patients and Tuesday, Thursday patients. And Friday was wrap up for anything else that comes along. We need to still get away from, I always visit my patients this many times a week. It's based upon need. Can your current orders be aligned to the HOPE timeline? You need to take a look at that. Will you need more PRNs for symptom management, as I just said? And will visit lengths of time increase? The admission has almost twice as many items now with HOPE than the HIS required that the RN has to do. So we might see, depending upon how the EMR helps us, we actually might see a little bit of an adjustment in the amount of time it takes to do an admission. Let me paraphrase this. This is an example. On an HUV visit, the patient says, hey, I've been so nervous in the last couple of days. I just don't, I can't even do the things that I want to do. And they said it was overwhelming. Their anxiety is overwhelming. You note that they have anti-anxiety medications, and you say, well, have you taken this? And they say, oh, I didn't know what that was for. You've all been there. So you say, well, let me give you some education on this medication. The nurse does that. The patient takes one. The nurse calls them back a couple of hours later, and they say, that was like a miracle. I feel so much better. Would you initiate, how would you score the anxiety? It would be a moderate to severe because the patient said it interfered with everything I wanted to do. I'd rate that as a severe. Would you need an SFV? Two hours later, they were perfectly fine. The answer is yes, you need an SFV. Fortunately, when you go out for this SFV visit, you will be able to say slight to none because you fixed the problem for them. Now, almost the last question, can you prevent an SFV visit, follow-up visit from happening? If you treat in the moment, you still can't prevent it. If the patient on admission, it's a look back for 2 days. You couldn't have prevented that one if they say moderate to severe. If on the HUV visit, if they say moderate to severe, I think you might have been able to prevent them by proper symptom management, really focusing all the time that you have the patients on service. If you have good clinical protocols that when you identify something that it gets treated very rapidly, by the time you show up for the HUV visit, you may have actually taken care of the problem and it's going to be, I don't have anything that is moderate to severe. And education of the patient to say, call me if there's a problem with a symptom, instead of waiting for you to show up for the next visit. And then that happened to be, of course, an HUV visit. And you're going to have to say moderate because they say it's impacting my ability to function today. So you can take a look at that. You might be able to prevent some of those SFV visits. And wouldn't that be why we're in hospice and what our patients expect from us anyway? Okay. Then my last slide is data submission. So don't think that HOPE is just for the clinical team, the referral center, the clinical team. It actually is for anybody who's currently doing the HIS submission. Are you going to continue to have them do that? What education do they need? Remember, there are those 4 submission points. And I know that somebody asked earlier, when do we submit the symptom follow-up visit, the SFV? And it's if it was identified at admission, the admission submission is going to include the SFV information. Same thing on the HUV1 and HUV2. It all goes in together at those 3 defined points of time. And you have 30 days for the submission to be sent in and accepted by the system. If you don't, then it becomes a problem for you. It becomes a negative entry. Hospice uses the queues, and I'm saying it wrong, but the queue system for HOPE submission, for the HIS submission. We're going to have to migrate over to the IQs for the HOPE submission. The information will be available for us on how to do that sometime in the summer of 2025. It's not there right this minute, but if you're billing people, the people who are going to be doing this really want to know how to work within IQs and you're not part of a home health agency, there is in the resources or references section, there's the bottom one talks about a link to CMS talking about how the home health migrated over. So that might be helpful for you. Also, there will be a validation tool available at some time this summer so that you can test your responses in advance of actually submitting them. Here is a list of and links to all of the references, or most of the references. There's more on there. As Judi said, there's a ton of information. There's a lot of YouTube videos from CMS accessible through the CMS website that you can use. So we encourage you to start looking at those things now.